Seizure disorder definition: seizure is the abnormal paroxysmal electrical activity in brain. Manifestation: motor, tonic clonic seizure, sensory, tingling, numbing, abnormal perceptions, behavioral changes, autonomic disturbances, sudden variation in heart or respiratory rate. Causes: provoked, for example, fever in febrile seizures, unprovoked underlying brain injury or dysfunction, epilepsy, recurrent, more than 2 episodes or seizures. Definition: febrile seizures. Definition: seizures provoked by fever alone without any underlying CNS infection or previous unprovoked seizure. Incidence: most common cause of seizure in childhood. Age affected: 6 months to 5 years old. Developmental status of patient is normal. Types: simple seizure, typical seizure, or atypical complex complicated seizure. Presentation: simple seizure, general tonic clonic seizure, atypical focal onset. Incidence: typical simple seizure is more common than atypical. Episodes of seizure: one during one illness. Multiple seizures are in complex. Duration is more than 15 in atypical. Reoccurrence: increased risk of reoccurrence up to 5 years of age. Risk factor until 5 years of age: major, age less than 1 year, duration of fever less than 24 years, fever more than 38 to 39 degrees Celsius. Minor, family history of febrile seizures, epilepsy, complex febrile seizures. Male, gender, hyponatremia at presentation, child in daycare setting. Number of risk factors. If there is zero risk factor, then there is 12% chance of febrile seizures. If there is more than equal to 3 risk factors, then there is 73 to 100% risk of febrile seizure. Risk factors for epilepsy more than 5 years of age. So risk factor, low risk factors are simple febrile seizure and recurrent febrile seizure, 1% to 4%. Risk of subsequent epilepsy, and it is higher in complex febrile seizure, more than 15 minutes in duration or recurrent within 24 hours, fever less than 1 hour before febrile seizures, family history of epilepsy, complex febrile seizure, focal, neurodevelopment abnormalities, high risk factors. Investigation to do is EEG and MRI. Lumbar puncture to rule out CNS infections. You do lumbar puncture like meningitis. Indications: any signs of CNS infection, meningeal signs. Recent antibiotic course can mask signs of meningitis. Unimmunized, unknown vaccination status. Management: treatment, control of fever, antipyretics, paracetamol, tepid sponging, cotton dipped in cold water, control of epilepsy, AIG, benzodiazepine, diazepam, lorazepam, midazolam, with no IV access, per rectal diazepam or intranasal imidazolam. Intermittent prophylaxis given during first 2 days of fever in home setting. Indication: major risks are present for frequently reoccurring febrile seizures, more than 3 episodes in 6 months or more than 4 episodes in 1 year. What you give is oral clobazam or oral diazepam. Absent seizure, petit mal seizure. Minimal manifestation. Age affected: school going children more than 5 years of age. Clinical features can last up to 30 seconds. Precipitating factors: hyperventilation used to diagnose clinically, and stress. Clinical features are vacant stares and eye flutters. Types: minimal manifestation, 3 Hz spike and wave pattern. Atypical can have GTCS or myoclonic seizures, 10 Hz spike and wave pattern. EEG finding 3 Hz and 3 per spike on wave pattern in typical absent seizure. This is the spike and wave pattern. Treatment: drug of choice in India is valproate. Second line drug is lamotrigine. Ethosuximide, limited availability and its use in India. Juvenile myoclonic epilepsy (JMB), Jan's syndrome, myoclonus, sudden jerky movements due to sudden contraction of muscle groups. Myoclonus is sudden jerky movements due to sudden contraction of muscle groups. Age affected as adolescence. Age affected is adolescence. Inheritance, polygenic inheritance, associated with mutations of CLCN2, Gabri, myoclonin, CACNB4 genes. CLCN2, Gabri, myoclonin, and CACNB4 genes. Polygenic inheritance of juvenile myoclonic epilepsy. These are the genes: CLCN2, CACNB4, Gabri, myoclonin. Clinical features: myoclonic episodes. It occurs upon awakening. For example, inability to hold toothbrush due to jerks. Myoclonic episodes occurs upon awakening, that is, inability to hold toothbrush due to jerks. Consciousness unaffected. Associated with other seizure patterns in some patients like GTCS and absent seizure. Precipitating factors: sleep deprivation, alcohol intake, 4 to 6 Hz polyspike and wave pattern. Treatment: drug of choice is valproate. Lifelong treatment due to increased risk of adulthood seizures. Epilepsy syndromes associated with injury to the brain, low IQ and developmental abnormalities. Epilepsy syndromes associated with injury to the brain, low IQ and developmental abnormalities. Rest syndrome, onset less than 1 year. Types: idiopathic 30%, not associated with CNS abnormalities. Symptomatic 70%, worst outcome: CNS defects is present. Clinical feature: infantile spasm, jackknife seizures, abrupt contraction of limbs. Salome spells, repeated neck flexion. Jackknife seizures, abrupt contraction of limbs, and Salome spells, repeated neck flexion. Developmental regression, loss of previously acquired milestones. Onset less than 1 year, high voltage spikes in chaotic background. High voltage spikes in chaotic background. Hips arrhythmia. Treatment: initiate at the earliest. Delay: irreversible brain damage. Drug injection: acetyl ACTH, adrenocorticotropic hormone. Second line drug: vigabatrin. Drug of choice if associated with tuberous sclerosis. Epilepsy syndromes, drug of choice is injection ACTH, adrenocorticotropic hormone. And second drug of choice is vigabatrin if there is tuberous sclerosis. Dravet syndrome, severe myoclonic epilepsy of infancy. Dravet syndrome, severe myoclonic epilepsy of infancy. Onset less than 1 year old. Genetic defect: SCN1A gene, 1 alpha subunit of sodium channel. Clinical features: multiple seizure types seen, difficult to manage. Management: first line drug valproate. Unsatisfactory treatment option: newer drug stiripentol, increased GABA activity, increased seizure. Management: first line drug valproate. Unsatisfactory treatment options: newer drug stiripentol, increased GABA activity, and increased seizure. Lennox-Gastaut syndrome. Onset 2 to 10 years. Clinical feature: developmental delay, typical EEG 1.5 to 2.5 Hz spike and wave pattern, multiple refractory seizures, and treatment is valproate, which is the drug of choice. Lennox-Gastaut syndrome, onset 2 to 10 years of age. Clinical feature: developmental delay, typical EEG 1.5 to 2.5 Hz spike and wave pattern, multiple refractory seizures. Treatment is valproate, drug of choice. Status epilepticus. Emergency characterized by long duration seizure. Timelines: T1, time at which treatment should be initiated, more than 5 minutes. T2 indicates prognosis, the time after which seizure activity may cause long-term consequences. Neuronal injury, that is after 30 minutes. That is T2. Treatment algorithm. Child presents with seizures more than 5 minutes at T1. Stabilize airway, breathing, and disability neurological plus attempt IV access. Blood glucose management. If hypoglycemic, less than 54 mg per deciliter, immediate push of 5 ml per kg of 10% dextrose is a result monitoring. 5 ml per kg of 10% dextrose. Continuous seizure. First line epileptic drug is IV benzodiazepine, midazolam, lorazepam. No response. Second line anti-epileptics. 1 of phosphatidylcholine, valproate, levetiracetam. No response. Refractory status epilepticus. Anesthetic dose of 1 of thiopental, midazolam, phenobarbital, and propofol. Continuous IV infusions, EEG monitoring for seizure activity.